Did you know that globally, the number of hip fractures in older adults, well, it's expected to surge up to 4.5 million by 2050?
It's a staggering figure.
It really is. And it's something of a silent epidemic, isn't it? With just devastating consequences.
Absolutely.
A fracture like this, it often means a huge drop in quality of life, loss of mobility,
Mhm.
and a frighteningly high mortality rate. We're talking 24% within just 1 year.
And even higher for those in care homes, sadly.
Exactly. The cost, both human and financial, it's just immense. Easily over £40,000 a year per patient here in the UK for the ongoing care.
Huge burden.
Welcome to the deep dive, our mission to, cut through the complexity and pull out the most vital insights from really challenging source material.
And necessary task.
Today, we're tackling something absolutely critical in healthcare: the best practices for managing hip fractures in older adults. And we're doing it by navigating a very comprehensive clinical practice guideline.
A really important document.
Guiding our dive today is our expert guest, brilliant at synthesizing this kind of complex medical information into clear, actionable understanding. It's great to have you back.
Thank you. It's definitely a topic where clarity rooted in solid evidence is just desperately needed, given the scale of the problem, and its impact.
Absolutely. So let's jump straight in then. Our source material is this clinical practice guideline, specifically for elderly hip fracture patients. Before we get into the what, maybe tell us about the how, who put this together, and, what makes it a reliable guide?
Right. So this guideline was developed by a really dedicated group of physician volunteers.
Okay.
They undertook a very rigorous, systematic review of the vast body of scientific and clinical literature out there.
Right.
And importantly, it was funded independently by the American Academy of Orthopedic Surgeons, the AAOS. So no industry influence here.
Ah, that independence is really key, isn't it?
Precisely. Their scope is specifically adults aged 65 and older, though they did cast a slightly wider net, including patients down to 55, if the average age in the studies they looked at was over 65.
To reflect the typical patient group.
Exactly. It reflects the usual patient population, and it's focused squarely on the acute management.
Yeah.
So from arrival at hospital through to that initial discharge.
Okay.
But it doesn't cover prevention or the crucial phase of post-hospital rehabilitation. Those are really complex areas in their own right, covered by other guidelines.
Okay, so focused on that immediate crisis period,
Yeah.
how did they sift through all that research? I mean, hip fractures must have been studied extensively.
They certainly have. They conducted really extensive searches across multiple databases. They started with a staggering 8,678 abstracts.
Wow.
And after multiple filtering rounds, they narrowed it right down to 212 articles that met their inclusion criteria for a full text review.
Gosh.
It's that kind of thorough process you need to build a solid foundation.
Just cutting down from over 8,000 to around 200 articles sounds like a massive job in itself. How did they then decide what the evidence actually meant and, what strength to give the recommendations?
Yeah, that's the crucial step. They used a formal process to grade the quality of the evidence itself: high, moderate, low, or very low. That's based on study designs, consistency of findings, things like that.
Right.
Then, crucially, they determine the strength of the recommendation: strong, moderate, limited, or consensus. And this isn't simply a direct translation of evidence quality. They use something called an evidence-to-decision framework.
An evidence-to-decision framework.
Okay.
Okay, that sounds a bit academic. What does that mean in practice for clinicians, for
Yeah.
patients?
It's actually very practical. It means they didn't just look at the raw statistics from the studies. They explicitly considered other factors too.
Like what?
Things like the balance of potential benefits versus the harms to the patient, the magnitude of the effect they saw in the studies, the feasibility. Can this actually be done in a real-world hospital? And also, whether patients would find it acceptable.
So wait, they could potentially give a moderate or even strong recommendation, even if the evidence quality was technically low? If, say, the potential benefit was huge and the harms were minimal?
Exactly. Or if it was simply the universally accepted standard of care already.
Ah,
It allows them to make pragmatic, clinically relevant statements, even when perfect, high-quality evidence isn't available. Which, let's face it, is often the case in complex surgical and geriatric care.
sure.
And conversely, they might downgrade a recommendation based on high-quality evidence if, for example, the potential benefits were tiny or the harms were significant for a particularly frail population. It's about balancing all these factors.
Right.
And notably, all the recommendations in this particular guideline achieved 100% consensus among the diverse group of experts involved.
100%.
Yeah.
That's impressive.
It is. It lends significant weight to their conclusions, suggesting these points are broadly accepted within the field.
Okay, right. Armed with that understanding of how the guideline was built, let's get into the findings. Starting with what happens the moment a patient arrives. Preoperative care. What did they find, especially regarding some perhaps traditional practices?
Well, one finding that might surprise quite a few clinicians relates to preoperative traction.
Traction, right, putting weights on the leg.
Yes. And the guideline issues a strong recommendation based on high-quality evidence against the routine use of preoperative traction for hip fractures.
Against it. Really, that feels completely counterintuitive. You sort of picture traction, helping align the bones, maybe relieving pain.
Well, that's the power of this kind of rigorous review. Studies consistently show that applying traction, it just doesn't offer any clear benefit, not in terms of reducing pain or improving fracture alignment before surgery, compared to simply positioning the limb comfortably with pillows.
No benefit at all.
None that's clear from the evidence. And worse, traction seems to introduce more problems.
Like what?
Things like constipation, pressure ulcers developing from being stuck in bed under traction, and even potentially increasing the risk of infection or bleeding complications.
So a common practice that might actually do more harm than good, or at best, offers no real benefit. That's a very clear takeaway right there.
It is.
Okay, what about the urgency of surgery? Is there a sort of golden window?
The guideline provides a moderate recommendation here. It's based on low-quality evidence, but it was upgraded using that evidence-to-decision framework we talked about.
Okay.
And it's for proceeding with surgery within 24 to 48 hours of admission.
Right, low quality evidence, but they still recommend it moderately. Explain that balance again.
Yeah, this is a perfect illustration of the framework at work. See, randomized controlled trials are incredibly difficult to do for surgical timing.
Ethically tricky.
Exactly. You can't ethically randomize people to deliberately delay surgery if you suspect it might be harmful. But the existing studies, though perhaps lower quality, consistently showed a trend. Surgery within that 24-48-hour window may be associated with better outcomes overall.
Better how?
Things like reduced pain, fewer complications, perhaps shorter hospital stays, and critically, delaying surgery beyond this window is generally associated with an increased risk of mortality and other complications, especially things like chest infections, pulmonary issues.
Okay.
So the potential benefit to patients, even with imperfect evidence, combined with those known risks of delay, that justified the moderate recommendation.
Right.
They do acknowledge, though, that hitting this target can be challenging. It depends on the patient's medical stability and, of course, the hospital's resources and capacity.
That makes perfect sense, balancing that imperfect evidence with the potential patient impact. Okay, moving to pain management. These fractures are, well, they're excruciating.
Absolutely. And here, the evidence is much clearer. There's a strong recommendation, based on high-quality evidence, for using multimodal analgesia.
Multimodal, meaning multiple approaches, not just one type of painkiller.
Precisely. And specifically including preoperative nerve blocks.
Nerve blocks before surgery?
Yes. Combining different types of pain relief.
Mm-hmm.
So, for instance, using a regional nerve block near the hip before surgery to numb the area, alongside PrEP's standard pain medication, it's proven by high-quality studies to give superior pain control.
And better outcomes.
Yes, and lead to better functional outcomes for patients afterwards.
Right, and managing blood loss during the surgery itself.
Another area with quite clear direction. There's a strong recommendation, backed by high-quality evidence, for administering tranexamic acid.
Tranexamic acid, okay.
This medication is well established. It's really effective in reducing blood loss during the procedure and consequently reducing the need for blood transfusions afterwards.
Makes sense.
And relatedly, the guideline includes a moderate recommendation, this time based on moderate quality evidence, about blood transfusions after surgery.
What's the guidance there?
It suggests that if a transfusion is needed in a patient who isn't showing symptoms of anemia, so they're asymptomatic, the hemoglobin level threshold used to trigger giving blood should be no higher than 8 grams per deciliter.
So be proactive about reducing bleeding with medication during surgery.
Yes.
And then be relatively conservative about giving blood afterwards if the patient is otherwise stable and not showing symptoms.
That sums up the evidence-based approach there, yes. Now, preventing blood clots, VTE, venous thromboembolism, that's a major concern for immobile patients, isn't it?
I imagine the risk is incredibly high after a hip fracture.
It is. Very high. Hip fracture patients are at significant risk for potentially fatal blood clots, like deep vein thrombosis, DVT, or a pulmonary embolism, PE.
Right.
So the guideline delivers a strong recommendation, This one was upgraded from moderate quality evidence, again, using that framework,
Oh.
that VTE prophylaxis should be used.
Should be used. Unequivocal.
Yes. The potential benefits of preventing these really serious clots
Yeah.
just far outweigh the relatively low risks associated with the preventative medication in this particular population.
Does it say which medication or for how long?
Actually, the guideline didn't find enough evidence to definitively recommend which specific agent or how long to use it for. But the core message is unambiguous. Use some form of VTE prevention.
A clear directive then, even if the specific drug choice is still down to clinical judgment. Okay, and lastly for pre-op, the choice of anesthesia, general or spinal.
Right. Based on high-quality evidence, the guideline makes a strong recommendation here
And that is?
that either spinal or general anesthesia is appropriate.
Oh, so no preference.
No. The studies reviewed showed no significant overall difference in outcomes favoring one type over the other. So the choice should really be made based on the individual patient, their overall health, the experience of the anesthetist, and the specific nature of the fracture and the planned surgery.
Okay, that covers preparing the patient. Now for the surgery itself, where the type of fracture really dictates the approach, doesn't it? Let's start with femoral neck fractures, specifically those that are unstable or displaced. These are the breaks right up near the ball of the hip joint.
Yes, exactly. For these challenging fractures, the guideline gives a strong recommendation backed by high-quality evidence for arthroplasty.
Arthroplasty, so replacing part or all of the hip joint.
That's right, replacing it, rather than internal fixation, which is trying to hold the bone together with screws or plates.
Why is replacing the joint better than fixing the bone for this specific fracture type in older people?
Well, studies have consistently shown that for these unstable femoral neck fractures in this older patient group, arthroplasty leads to significantly better long-term results.
Better how?
Patients tend to have less pain, better function, fewer complications overall, and crucially, a much lower chance of needing a second operation because the initial fixation failed or caused problems later on.
Ah, the reoperation rate. That's key.
It is. The mortality rates were actually similar between the two methods, but the quality of life and that need for reintervention were strongly in favor of replacement.
Okay, so if arthroplasty is the choice, what type? You hear about hemiarthroplasty replacing just the ball versus total hip arthroplasty replacing the ball and socket. What about the implant itself?
Okay, so for hemiarthroplasty, where just the femoral head, the ball is replaced, there's a moderate recommendation based on moderate quality evidence,
Saying what?
stating that both unipolar and bipolar implants are equally beneficial. Studies just didn't show a significant difference in patient outcomes, pain, or function between these two slight variations on replacing the ball component.
So either type of hemi is fine. What about comparing hemi to a full total hip arthroplasty, THA?
Right. Comparing hemi to THA replacing both components, there's a moderate recommendation, but this one was actually downgraded from high-quality evidence.
Downgraded. Why?
The guidelines suggest that THA may offer improved functional benefits over hemiarthroplasty, but this seems to be primarily in carefully selected patients, perhaps younger, more active, older adults.
Okay.
But there's a significant caveat. THA carries a higher risk of certain complications compared to hemiarthroplasty, particularly dislocation.
Ah, dislocation is a major concern with hip replacements.
It is. So you have potentially better function, but with a higher risk profile.
That sounds like a situation needing a very careful conversation with the patient and their family.
Absolutely. And as you hinted, it also generally involves a higher cost for the implant itself and potentially the procedure fees.
Right.
The guideline actually highlighted that more research is needed here, particularly looking at how surgical timing and the surgeon's experience with THA specifically for fracture cases might influence these outcomes and complication rates.
More research needed there. Okay, what about the specific implant type for the femoral side, the stem that goes into the thigh bone in arthroplasty?
Yes, for the femoral stem, there's a strong recommendation based on high-quality evidence for using cemented femoral scums.
Cemented stems. Interesting. I thought uncemented was becoming more common in, say, elective hip replacements. Why cemented specifically for fractures in the elderly?
That's an excellent point, and it really highlights how fracture patterns in older, often more osteoporotic bone are different from arthritis cases.
Different bone quality.
Yes. The evidence strongly supports cemented stems for this specific patient population with hip fractures. They're associated with better short-term patient outcomes, more reliable fixation in potentially poorer quality bone,
Okay.
and potentially a lower risk of fractures occurring around the implant later on, paraprosthetic fractures, compared to uncemented stems.
So better immediate fixation and maybe fewer late complications.
That's what the evidence suggests. While putting in a cemented stem can sometimes take slightly longer in surgery and might involve a little more blood loss during the procedure, the evidence on improved outcomes is compelling.
And cost.
And cemented implants are generally less expensive as well.
That's a really key detail, the specific demands of fixing a fracture in potentially weaker bone driving that recommendation. What about the surgical approach itself? From the back, the side, the front. Does the evidence favor one?
Here, the guideline has a moderate recommendation based on moderate quality
He
evidence.
says.
It states that the evidence does not clearly favor one surgical approach over another overall,
Really? No winner?
not definitively. They looked at studies comparing posterior, minimally invasive variations, direct lateral, and direct anterior approaches. The findings were, well, pretty mixed regarding short-term benefits like initial pain levels or how quickly patients started walking.
Okay.
Importantly, long-term outcomes and overall complication rates were often similar across the different approaches studied.
So it seems like maybe the surgeon's familiarity and expertise with a particular approach are probably the most critical factors here, rather than one approach being inherently superior based on this evidence.
Based on the current evidence review for this guideline, that certainly appears to be the case.
Okay. Now let's shift focus slightly to intertrochanteric fractures. These are lower down the femur compared to the femoral neck, sort of outside the joint capsule itself, but still part of the hip region,
That's right, a different fracture pattern.
and often requires a different hardware solution, right?
Exactly. The type of implant usually depends on whether the fracture pattern is considered stable or unstable.
Let's start with stable ones.
Okay. For stable intertrochanteric fractures, there's a strong recommendation based on high-quality evidence
And the recommendation is?
that either a sliding hip screw or a cephalomedullary device is recommended. Both are good options.
Could you just briefly explain the difference between those two types of implants again?
Certainly. A sliding hip screw is typically a plate that runs along the side of the femur, fixed with screws, and it has a large screw that slides into the head of the femur. It's an extramedullary device, meaning it sits outside the bone marrow cavity.
Okay, outside the bone.
Whereas a cephalomedullary device, often called an intramedullary nail or IM nail, is actually placed inside the bone marrow canal of the femur. It's a rod inside the bone, with screws going up into the femoral head to hold the fracture.
Ah, okay. One outside the bone, one inside. And for stable fractures, the evidence shows they both work equally well.
That's right. High-quality evidence shows similar clinical outcomes, things like walking ability, hospital stay length, and complication rates like fracture collapse or implant failure when using either device for these stable patterns.
Okay. But what about the unstable ones?
Yes, for unstable intertrochanteric fractures, and this includes patterns like subtrochanteric extension or what's called reverse obliquity, where the bone fragments are just less stable and rotational forces are a bigger issue.
Right, more complex breaks.
Exactly. For those, the picture changes. Here, there's a strong recommendation, also based on high-quality evidence, that patients should be treated with a cephalomedullary device, the intramedullary nail.
So, for unstable breaks, the nail inside the bone is strongly preferred over the plate on the outside. Why the clear preference here?
The evidence is quite strong for these unstable patterns. Intramedullary nails provide better biomechanical stability. They're better at resisting the forces that want to displace these unstable fragments.
Mechanically stronger for that situation.
Yes. Compared to sliding hip screws, studies looking specifically at unstable fractures show a significant treatment benefit with cephalomedullary devices. This can include potentially improved walking ability and sometimes fewer blood transfusions needed, perhaps due to reduced surgical trauma, compared to fitting a plate. It's just a more reliable construct for these more complex fracture patterns.
That's a crucial distinction based on fracture stability. Now,
Yep.
what about the length of that intramedullary nail? Sometimes you hear about short versus long nails. Does the guideline address that?
Yes, it does. This is addressed as a limited option based on moderate quality evidence,
A limited option, meaning?
meaning both short and long cephalomedullary nails are considered acceptable treatment options for pertrochanteric fractures, which includes many of these intertrochanteric patterns. There isn't strong evidence favoring one over the other definitively.
So what did the evidence actually show when comparing them?
Well, studies comparing short and long nails for these patterns suggest that short nails might have some minor advantages. Things like potentially less operating time, maybe less blood loss, or reduced X-ray exposure during surgery.
Okay, some potential procedural benefits.
Yes, but importantly, there wasn't a consistent, significant difference found in overall adverse events or those really important patient outcomes like walking recovery or final function.
So similar outcomes overall?
Pretty much. Interestingly, though, some lower quality evidence hinted at a potentially higher risk of paraprosthetic fracture. That's a fracture around the implant itself with the short nails.
Ah, okay. So short nails might be slightly easier or quicker to put in, but the long-term functional outcome might be similar. And there's maybe a slight question mark, a potential signal of a higher risk of another fracture around the nail later on.
Exactly. And because of that uncertainty and the moderate quality of the evidence, the guideline notes this as an area really needing more high-quality research to provide a more definitive answer. Hence, it remains a limited option rather than a stronger recommendation.
Okay, understood. We've navigated the surgical maze there. Let's look at what happens after the journey towards recovery. What stands out as the most impactful postoperative recommendation?
Probably the most strongly supported postoperative recommendation, and this is based on high-quality evidence, is the use of interdisciplinary care programs. The guideline makes a strong recommendation that these programs should be used.
Interdisciplinary care programs, what does that actually look like in practice? What is that for a hip fracture patient?
Well, it really means moving away from just the surgical team managing the patient in isolation. It involves a properly coordinated approach, bringing together orthopedic surgeons, geriatricians, doctors specializing in elderly care.
Crucial for this group.
Absolutely. Plus nurses, physical therapists, occupational therapists, social workers, and potentially others like pain specialists or nutritionists. It's a whole team.
Working together.
Working together, yes, to manage not just the fracture recovery itself, but also the patient's overall medical health, their cognitive function, nutritional status, psychological well-being, and their social support needs for discharge.
So really treating the whole patient, not just the broken bone. Does the evidence truly show this makes a big difference?
Unequivocally, yes. The evidence is really strong on this. These coordinated programs are proven to significantly decrease complications during the hospital stay and improve overall outcomes. Studies show reduced in-hospital mortality, fewer medical complications like pneumonia or cardiac events. And while the evidence on longer-term things like functional recovery, mobility, and return to their previous living situation showed positive trends, some studies specifically reported significant improvements in patients' cognitive status and a reduction in symptoms of depression.
That's powerful, suggesting it helps with both physical and mental recovery, which is just so vital in this older population. The guideline mentioned feasibility. Are these programs easy to implement everywhere?
While the guideline notes that feasibility has been shown, meaning it is possible to set these up in hospitals, however, it also points out that more robust data is probably needed on the specific cost-effectiveness of these programs compared to more traditional care models.
Right, the cost argument. Always a challenge in scaling up what we know works. Okay, one more key post-op question. Getting patients moving. Weight bearing. Should they be up and walking immediately, or should it be restricted?
Yes. This is listed as a limited option, and it's based on very low-quality evidence that was actually downgraded.
Very low quality and downgraded. Okay.
Yes. The guideline states that immediate weight bearing as tolerated by the patient may be considered.
May be considered? That doesn't sound like a ringing endorsement based on very low quality evidence.
It isn't, no.
Mm.
It really highlights the lack of strong evidence to definitively say immediate weight bearing is superior or even safe for all patients or all fracture types and fixation methods.
So what's the thinking?
Well, there's potential for benefits, maybe faster functional recovery, reduced length of stay, possibly lower overall costs. And the feasibility is supported by the fact that most patients do eventually bear weight as tolerated anyway.
But
There's still significant variation in practice. The guideline noted that roughly 25% of providers still apply some form of weight-bearing restriction after surgery.
a quarter is still restricted.
Yes, which indicates a lack of universal agreement, or, perhaps more accurately, insufficient evidence to change that practice definitively for everyone. It really remains an area where clinical judgment, based on the specific fracture, the fixation achieved, and the individual patient factors is absolutely crucial.
That makes sense. So looking back at this whole guideline, it really feels like a critical map through a very complex landscape.
It truly is. I mean, taking thousands of research papers and distilling them down into practical, evidence-graded recommendations requires immense effort and a really rigorous methodology like the one used here, including that evidence-to-decision framework.
Yeah.
It provides clear directions in many crucial areas, even if it also honestly highlights where the evidence is still thin and, frankly, more research is needed. It helps clinicians make the best possible choices for their patients based on the current knowledge base.
So if we were to pull out the absolute essential takeaways from this deep dive, the things you really need to know about best practices for elderly hip fractures.
Okay, well, several points are really critical and well supported by evidence. First, forget routine preoperative traction. The evidence is strongly against it.
Right.
And second, aiming for surgery within that 24-48-hour window, it may improve outcomes, even if the evidence quality itself is lower.
Okay.
Third, preventing blood clots with VTE prophylaxis is essential. That's a strong recommendation.
Let's do.
Fourth, effective pain management using multiple methods, definitely including nerve blocks, is key. As is using tranexamic acid to reduce surgical blood loss. Both of those are strong recommendations.
Got it.
Fifth, for specific fracture types. Those unstable femoral neck fractures should ideally be treated with arthroplasty, using a cemented femoral stem.
Arthroplasty with cement.
And unstable intertrochanteric fractures are best managed with a cephalomedullary device, that intramedullary nail.
Nail for unstable intertrochs.
And finally, post-operatively, implementing those interdisciplinary care programs is a strongly recommended, evidence-backed way to improve overall patient outcomes.
Those are incredibly valuable insights, really boiling down years of research into practical steps. Thank you so much for expertly guiding us through this vital area of care.
It was a pleasure. Getting these evidence-based practices into wider, consistent use across the board, that's really the next big challenge, isn't it?
It certainly is. If you found this deep dive valuable, please do consider rating and sharing the show. And finally, a thought to leave you with. While comprehensive guidelines like this provide strong guidance on how to optimally treat hip fractures based on evidence, how do healthcare systems truly ensure these best practices are consistently implemented across all hospitals, all care settings, especially when faced with those practical challenges, the resource issues, and the varying provider preferences that the guidelines themselves sometimes touch upon? It leaves you wondering, doesn't it, about that gap between knowing what to do and consistently doing it everywhere for everyone.